Good afternoon. My name is Krysten Pilkington. I'm an acute care nurse practitioner at the Arkansas Heart Hospital. I've been here for almost 5 years. I've had the pleasure to work with some excellent cardiologists. I have primarily worked with Dr. Vasily Lendl and as well as Dr. Sherbet and Dr. Nash over the past many years. My role as nurse practitioner inside the hospital is both pre-procedural and post-procedural management of our patients with coronary artery disease. We frequently have patients coming in with angina symptoms who need care, and I help both with the assessment process but also the management. So when our cardiologists take patients for procedures, they frequently end up with percutaneous coronary interventions, splenic angioplasties, or drug-eluting stent or bare metal stent placement. So the purpose of this conversation today is anticoagulation and antiplatelet therapy post-stenting. We will primarily be discussing stents placed during percutaneous coronary intervention. There are stents that are placed peripherally, but for this discussion, it will be coronary interventions. Guidelines are coming from the American College of Cardiology. We will go over them here, but if you are looking for guidance, especially in a primary care setting for why we're doing what we're doing, this is where we get those guidelines. Briefly, coronary artery disease or coronary atherosclerosis is a disease process where cholesterol accumulates as plaque and blockage in the inner lumen of the coronary arteries, which blocks oxygenated blood flow to the myocardium. When this blockage reaches 70%, the patient may start developing symptoms such as chest pain, shortness of breath, activity intolerance, or what have you. At this point, ischemia is assumed and the patient is taken for percutaneous coronary intervention. That usually involves some kind of stent placement. There's 2 stents to discuss. The first one is a drug-eluting stent, which means that the stent itself is actually coated with a medication that delays the healing of the endothelium. So the endothelium will try to create a kind of like a scar tissue inside of the stent and start to block off blood flow again. So in order to allay that, we use these medicated covered stents. While we are letting the endothelium heal slower, that does create a longer time frame for platelet aggregation to occur. Therefore, antiplatelet therapy is indicated. Bare metal stents are the other type, and they do not provide that protection from scar tissue formation. Therefore, endothelial healing doesn't take as long, and antiplatelet therapy length of time is not as long as drug-eluting stent. So our goal is to allow for the endothelium to heal at a slower rate so that scar tissue doesn't form inside of that stent. However, during that healing process, we are not trying to let the platelets aggregate to create like a thrombus inside of the stent. This is just a quick overview of the coagulation cascade. There's 2 sides of it. If you look on the left side, it is the thrombin production. On the right side, you'll see the platelet aggregation. That's the side that we are going to be focusing on. So when Dr. Murphy asked me to do this presentation, it's very difficult to find a very polite graph showing coagulation cascade, how it happens, and where it happens. So you'll just have to look at the one that I made myself because I couldn't find one that I liked. So if you look at the top left, that's your aggravating factor. You have endothelial injury and platelets that are already activated, and then that starts the cascade. So you have the things that you see inside of the arrow, which is like von Willebrand factor, ADP, COX-2, and thromboxane. This is where your aspirin starts. It is a COX-2 inhibitor, which tries to slow thromboxane production. These mediators attach themselves to the P2Y12 receptor that is on the platelet itself, therefore activating the platelet. So our goal is to try to stop that from happening. So aspirin is your first line of defense. It does take a little bit of time to reach peak activity. You'll see 1 to 2 hours, which is why you've seen that patients are told to take aspirin at home prior to making their way into the hospital, because it does take a little bit of time to start its antiplatelet therapies. If the P2Y12 receptor is activated, it will further the platelet aggregation So this is where your P2Y12 inhibitors come in. They selectively bind to that receptor on the platelet, which then, again, tries to stop the platelet aggregation. These medications you've seen, Plavix, Effient, and Brilinta, these are your pill form antiplatelets. You can see they do have a delay as far as peak activity time. So therefore, there are actually studies going on right now to determine if loading patients with these medications prior to PCI is helpful. It is helpful if you're basing that information on, just being therapeutic in a timely manner. However, the risk of that is, of course, if the patient were to need bypass surgery, and then you would have to let that wear out before then. If the P2Y12 receptor is activated, then it activates the glycoprotein 2B3A receptor. And that's the final pathway for your antiplatelets. This is where your medications such as Riapro, Integralin, and Aggrastat go in, and they adhere to that receptor and block the way that way fibrinogen cannot adhere, because that's when fibrinogen would connect to other activated platelets and therefore create your thrombus. These medications are potent antiplatelets. They are known to reduce the mortality in patients with significant thrombus burden. However, because they are so potent, they are with a higher risk of bleeding. So if a milder and safer antiplatelet is available to be used, it will be used. It's used for acute coronary syndrome. It's also used in instances of like distal embolization. So they definitely have their place in our antiplatelet world. This is one more little picture that I really liked. You can see all the way on the right what aggregated platelets look like, and they have the fibrin that have attached to them, where the fibrinogen has attached to that 2B3A receptor, and you can see looking backward how it was activated. The American College of Cardiology have a really nice summarization of their guidelines for us, and this is what we utilize when we're deciding what to put these patients on. So I won't read them all to you because you can read, and you could also look them up if you wish, but aspirin is almost always continued indefinitely. For patients who have a drug-eluting stent, 6 to 12 months of a dual antiplatelet therapy, which is aspirin and either Plavix, Effient, or Brilinta. In patients with acute coronary syndrome, they should be on it for a minimum of 12 months. For information for both our primary care as well as any other specialties, if the patient should require non-cardiac surgery, then that should be delayed for, like we said, 30 days after bare metal stent placement or 6 months after drug-eluting stent placement. So we'll just talk about, we have a couple patients to discuss. So Mr. Johnson, 65-year-old male patient, presented to Arkansas Heart Hospital with complaints of substernal chest pain. He had a bump troponin as well as hyperglycemia. He was presumed to have non-STEMI. He was taken to the cath lab, and he was given 2 stents. Unfortunately, post-procedurally, he was unable to swallow. He could not take his antiplatelet therapy, but as we know, we need to be on that if we're not going for immediate surgery. Cangrelor drip was initiated for this patient. This is a good option because it has a quick onset, quick offset, and it is a good antiplatelet therapy, which will keep that stent open while we're waiting for the patient to be able to swallow. Next one is Ms. Jones comes in with her complaints similar to angina. She has chest pressure described as squeezing pain with some chest pressure. She unfortunately has a history of gastrointestinal bleeding, and therefore antiplatelet therapy is riskier for her than for most patients. However, she did require angioplasty, and the cardiologist elected to place the bare metal stent, which will require 30 days as opposed of dual antiplatelet therapy as opposed to 6 months to a year. So approximately 10% of our patients do require both anticoagulation in addition to antiplatelet therapy. And this is required for patients with atrial fibrillation, or let's say they've had a DVT or a PE. And so this is where our DOACs and our vitamin K antagonists come in. these medications are, especially the DOACs, they're effective. They have less risk than warfarin does, simply because patients are frequently out of their target INR range. I'm hopeful that someday, which will be a wonderful day, is when these medications become more affordable for our general population. But at the moment, they do give us a little bit of trouble with that. So if we need to have anticoagulation in addition to antiplatelet therapy, there's American College of Cardiology has some opinions on that. And so if the patient only needs to be on aspirin for primary prevention, we can switch them to anticoagulation only. If they are requiring dual antiplatelet therapy, we should maintain the Plavix, Effient, or Brilinta in addition to the anticoagulant, and we should drop the aspirin. Again, these are guidelines that you can look these up. They are pretty standard across the board. The big thing I want you to take away from this is that triple therapy is not recommended. If it is absolutely necessary, they recommend no more than 30 days because it does not seem to have long-term benefit for the patient, except they will have higher risk of bleeding. So if this is necessary, or if primary care sees this, please do have the patient follow up with cardiology, because we need to address this. Frequently when this happens, it's just because of a miscommunication at either discharge or follow-up, and they've decided to keep their aspirin. Our last patient is Mr. Davis. He presented to the Heart Hospital emergency room with fluttering and shortness of breath. He was noted to be in atrial fibrillation. He's never seen cardiology before, and he had a bump troponin. He was taken to the cath lab and had 2 stents placed. He was loaded with clopidogrel, and he does need anticoagulation because he's in atrial fibrillation. We will continue the Plavix at this time, and we will also maintain the anticoagulant, but we will not include aspirin in this patient's care. Last thing to consider is just our patient education. Like we said, patients will be more compliant if they are more informed. If they know about potential side effects of medications, they are likely to understand why they need to be on it. So if, for example, Brilinta is a wonderful medication for antiplatelet therapy, but it does have a transient shortness of breath side effect to it. If the patient knows that going in, they will likely be more compliant and either push through or call our office with concerns. And we ask the same thing from primary care. If you'll have any questions about anything that we're doing, please call, and we will be happy to discuss it with you. And that's all I have for today. Thank y'all for your attention.